pharynx, and tongue, and the floor of the mouth. Are you guys familiar with the Velscope? Any of you, have you guys used it?
It's like a type of
Yes.
equipment that has a light on it, I believe.
Yes. I think that once you guys finish your program and get out and start practicing in the office, I think it's an amazing screening tool. I have that in my office. I can actually include a link in the classroom once we're done today. I use it in my office along with the visual exam that I do. It's just whatever you miss just with the visual, this helps it. I've diagnosed quite a few cases over the years, and it's basically a blue light. It's harmless. That's emitted into the mouth, and if there's any suspicious lesion, precancerous or cancerous, it absorbs it, and through your scope it appears as black. Otherwise, healthy tissue basically transmits that as fluorescent. So anyway, with the oral cancer signs and symptoms, you're basically looking for symmetry. You know, you're checking the buccal mucosa, you're checking the tongue. You want to make sure there's symmetry and there's no discoloration or changes on one side compared to the other. So you keep an eye on it. You have the patient also monitor it. If they notice any lump that isn't disappearing or any redness that isn't disappearing after 2 weeks, you have them come back, and then you refer them to an oral surgeon for a biopsy and get that sent to an oral pathology lab. Here with the examination of the lip, you know, you see here like the vermilion border. Out here it tends to be more kind of more herpetic, more viral out here. It's inside the mouth where it tends to be more like the abscess, ulcers, the oral candidiasis, things like that. There's thousands of oral diseases, okay? I mean, there's something I even encounter sometimes that I'm a little stumped on or haven't seen in a long time. So I think it's important also for you guys to invest in a small pocketbook on oral diseases. I went ahead and included that in your classroom. You could buy it on Amazon. I think it's for about maybe 20 or 30 bucks. Worth having, especially if you encounter something. And there's a lot of pictures in there too to help you, because some of these lesions look so similar to others. So I mean, not really expected to be diagnosing all this, but just documenting it and referring it to an oral surgeon to then do the further biopsy and assessment on that. Okay. So I'm covering just more of the basic top 5 to 7 lesions that you may encounter in the practice. So here with the size of the lesions, you'll see common ones like this one, the mucus seal, which is typically caused by like biting, injuring it, more of a salivary gland issue. These are a little tricky to its size. Abscess ulcer, it's another common one. I'm sure you guys have seen over and over again. More due to herpes, oral thrush, the different textures. These are pretty self-explanatory. The different types of lesions. You got fixed and mobile. I gave here a couple examples, like a fistula tract 1 or abscess, and something a little bit more fixed, like a fibroma or mucus seal. This is an example of fibroma. Now, with the pain, obviously, patients are going to be the ones that are going to be telling you. It's unless it's something like a periapical lesion that is pretty acute that you can see on the radiograph, that you'll let the patient know that there's, and then they'll be surprised about. Otherwise, they typically kind of let you know the pain that they're experiencing. So you want to definitely document that, and then have the doctor come in and help you diagnose it further. Onto the intraoral examination. I'm sure you guys have encountered this many times. Cheek biting, that's a common one that you'll find here. This one being a linea alba, especially common if they're sleeping on one side, have their cheek resting on that side. They tend to gnaw on that. You also have Some people do daytime clenching and biting.
Doctor, I have a question. For
Yes.
the linea alba on the side right there with that white line, I've seen some patients who are in like ortho treatment as far as like Invisalign and Clear Correct.
Yes.
I've seen some of the patients with that line on the side of the cheek. Is that due to like, because I mean, with my experience with my Invisalign, I got a lot of dry mouth. So I mean, would that be like a reason for that, or is it just because of what you had mentioned?
I think partly is just having another appliance in your mouth.
Okay.
You're having this appliance in the mouth, which also leads to dryness of the mouth, and it's just easier for you to pinch your buccal mucosa in there and to cause that. I've encountered that too sometimes. I myself too. I wear an occlusal guard, and sometimes I wake up with soreness in my mouth, and you can even get the linea alba for sure.
Okay.
You can absolutely get that. Now onto the oropharynx. With this, when you're doing the oral cancer screening, you retract the tongue down, have them say ah, that way that'll help you visualize and see the oropharynx all the way in the back, as well as the tonsils in there. The only group you're going to have a hard time being able to see that is basically here with a class 4 patients. These are the people that tend to also suffer from like a sleep apnea. You've seen those really large male patients, larger than the 16 or 17 inch thick neck. They tend to also have trouble breathing. That when you do that, don't fight the tongue. You're not going to ever be able to see that back there, the oropharynx area. For the most part, in that group, you're going to just try your best and move on. And with the floor of the mouth, the same thing. What I normally have them do is I have them get their tongue and touch the roof of their mouth with their tongue for you to be able to visualize that. And then you go in there and you palpate with your finger at the floor of the mouth. I put one finger in the mouth and then your other finger's outside submandibular, and you're trying to find any masses in there or any blockage from like the salivary duct. Those are common things. This is going to be pretty rare. This form of a cyst mucus seal here, ranula. But obviously anything like that, refer out to neurosurgeon. Now with the tongue, use some of the common things you'll find: fissured tongue, and or if you complain of pain, abscess ulcers typically is the most common one. You're gonna have them stick your tongue out, and with the gauze, move it to the side, and you're gonna be checking the lateral borders as well as the dorsal and ventral, looking for symmetry. If there's anything abnormal, document, refer to neurosurgeon. These two are real common too, as I mentioned earlier, the fissured tongue, the geographic tongue. This one's interesting. This one changes in pattern, and they're really no known cause, typically a genetic trait, but it's benign. This I would not worry about. You're going to hear patients complaining of irritation of the tongue, almost like a burning tongue when they have to be spicy. Sometimes with the fissured tongue as well. Nothing that really can be done about that. I included a video of the intraoral exam that I did recently. Here's a link of that video, but it's also in the classroom. Dr. Germani went ahead and put it out on YouTube. Okay, you guys can check that out in your spare time. And the abscess ulcer here again. The most common reason I've seen is due to like chemical irritants or like allergies. Sometimes even like cinnamon flavored toothpaste, stress, deficiency in vitamins, certain medications. Those are most common reasons. Have you guys seen this one before? The angular colitis? Any of you? Yeah. Common one too. This one, obviously, you're going to treat with just an ointment, antibacterial ointment or antifungal. That like a nystatin. Nystatin's a common one, and it comes as a cream or as an ointment. You have the patient apply that liberally 3 to 4 times a day until it resolves. You're going to find this more common in your denture wears, where there's a loss of VDO, or patients that are missing back molars or have really ground down those back molars where now the VDO has dropped and you have a somewhat of a fold now over their lower lips, or if there's dryness of their lips and they're now starting to lick their lip. Those are common reasons why. Kind of skipped over the abscess ulcer. Could be painful and annoying, 7 days to 10 days of heal time. And it can happen, it can recur anywhere from 3 to 4 times up to 7 and even 10 times a year, depending on the size of the abscess ulcer, if they're larger or smaller. The milder ones are more 3 to 4 times a year. The larger abscess ulcers take a little longer to heal and can reoccur up to 10 times a year. Mucus seal, this one's an interesting one. This one sometimes isn't as obvious as the pictures that I showed here. Sometimes the patient will feel a bump, but you may not be able to see the bump in their lip. Sometimes it's trapped due to the salivary gland and it's trapped inside of the lower lip.
Lesson, sorry, there's a patient that has that, and he said he bit it and it went away, and then it came back.
Yes. Good question. So with that, yes, sometimes it goes away. But you know what, my experience, it's pretty rare for that. Refer to the oral surgeon, have them remove it entirely. It's a blocked salivary duct there, and it just keeps coming back. As a matter of fact, I used a laser to try to remove one a while back, and it's tricky. If you even leave a tiny bit of that left, and visually it looks like it was all removed, it can grow and come back.
Yeah, that what happens to the patient. Like he went and get laser out, and then it came back, and then he bit it, and then it went away.
Do you see what I mean? Those are real tricky. I stopped treating those because at least in my hands, it wasn't working. I would remove it. I'd use the laser. Yeah. It looked like it would all be removed, and it would come back. So those are real tricky. Just look out for that. I wouldn't mess around, or either you or you're having your doctor trying to remove that. I would just have them refer to the oral surgeon and have them just excise everything out.
Okay. Thank you.
But again, harmless. The mucus seal, mostly due to injury. With the gingiva here, you guys all have enough experience and seen plenty of this, where you can tell what's a healthy gingiva and what's not. Nice and pink, where you put the periprobe in there, you get a tiny little resistance and blanching. That's a good sign. And with no deep pockets greater than 3 millimeters, that's what you want to look for. The stages of gum disease, as all of you guys know, fiery red tissue, deep pockets, and confirming that against a radiograph with vertical bone loss. Those are all signs of gum disease, which would then require scaling and root planing. On to the tooth numbering systems. Here we pretty much use a universal one. Orthodontists, typically I've seen them use more the Palmer notation, which we'll go into. You guys are all familiar with this already. I'm going to go ahead and skip that. This one we don't use here. And this one's the one I typically see with the orthodontist using, with the brackets. And with the charting, this one seems to be pretty self-explanatory. We covered it just a little bit earlier. Red, pending treatment. Blue's been completed. With amalgam filling, you want to fill in. With composite, you just want to do the blue outline when it's completed. The same thing with the crowns. The PFM crowns, so gold crowns, those you tend to fill in more, and then the porcelain crowns, just the outline. And Dentrix and some of the other softwares all have this preset already. And here I'm giving you an example of one from my office. It's all preset. I'm sure you guys are very well familiar with this already. Self-explanatory. Any questions so far? No? Okay. Onto the soap notes. When you're writing your notes, it's important to always use the soap notes. And this one too, you're going to basically write down what the patient tells you that they're experiencing, and the chief complaint, pain, when it started, how long they've been having it for, and then objective is what you're seeing. What you're objectively seeing, what you're seeing on the x-ray, everything, you're basically documenting everything down. The A would be what's been diagnosed and recommended, and then the plan, basically what you plan on doing to take care of the issue, right? Here's an example. Okay, so on to the GV Black's classification of cavities. You guys are well aware of this already. You know the class 1, the class 2s, the class 3s and 4s, and the 5s. The 5s get a little tricky sometimes with restoring. As you guys have seen, I like to use a resin-modified glass ionomer for the class 5s, because depending on the size of that class 5, if they're too large, those composites tend to pop out because the teeth, they all have that flexure of elasticity, and the composites are very rigid. So I'm sure you guys have seen those too. You've seen that fraction, and that film can pop out. So I like to use a glass ionomer that's a little bit more within the same consistency, and will hold better against the tooth. Okay, now on to alignment and malocclusion. We got the overbite. Basically, when you have the maxillary teeth overextending well below the 2/3 of the lower anterior teeth. Okay, overjet, if they're sticking out greater than 3 millimeters from the mandibular edge to edge, that one you guys are aware of. Open bite, and then cross bite. That one's more of anterior cross bite, where the mandibular teeth are basically over the maxillary teeth, right? Over some pictures next. There's a class 1 here, where you have that mesiobuccal cusp, basically right over the groove of the mandibular first molars. And then you have here a class 2, where now the maxillary teeth, will hold maxillary arch is advanced forward, and now you have the distal of that first molar closer in line to the groove of the mandibular first molar. Here's another better picture of it. And definitely with these, refer them to orthodontists. The younger they are, the better it'll be for the kids. Because sometimes it's even more of a skeletal issue, and that way, the younger they're put in the ortho treatment, the sooner everything can be corrected. It gets harder to correct after they've grown. And then we got the class 3 now, where now it's in the opposite direction. Now you have that mandibular jaw advanced more, kind of more of that Jay Leno jaw with the anterior crossbite. Bit of the overjet here that I was mentioning earlier. Overbite. Some cases are more severe than others with this. The open bite. A lot of it is due to the habit that they have, thrusting their tongue out as kids, or even thumb sucking. So again, for this, you refer them out to the orthodontist. Crossbite. This can lead also sometimes to cheek biting, because now you have the mandibular teeth overlapping the maxillary when it should be the other way around. The edge to edge. With the edge to edge, there's a new treatment out there by Invisalign called Invisalign Go. I don't know if some of you have heard of it. It's an amazing, amazing tool. You guys can download that app. And basically with this would be a good case for an Invisalign Go, where you basically, with the Invisalign app, take pictures of their teeth, and within a minute or two, it lets you know if they're a good candidate for Invisalign. And it's basically like an Invisalign Express, where they can have the treatment completed within 5 months. So this will be a good case like that, where it can be straightened out in no time. We do Invisaligns too, so it's a good service for you to offer patients too. Overcrowding. And then with the gap teeth here too. Anything like this, definitely, they may have some periodontal disease. And now we jump onto the gingiva. You guys already know what to look for. Nice, light pink, healthy gingiva that doesn't have any spontaneous bleeding when you do the perio probing. When you're doing the periodontal probing, healthy 2s and 3s, anything above a 3, you want to definitely mark in red. And if you're using a tooth chart like Dentrix, it's already set for you. It'll all be in red. Here's an example here. It's kind of shaded in gray here, but you notice anything with a 4 and above, it's going to be in red, and you can just mark everything on there, and the bleeding spots as well, and any furcation involved too. It's in the app where you can add that. With the intraoral photography, any of you guys that are that may be serious and wanting to start doing photo documentation or helping the doc with any of his or her cosmetic procedures, you can go to photomed.com, and there you can buy any supplies in there, or even a camera that comes preset for dental. Or if you're wanting to set it up either for your doctor or for yourself, make sure you have the cheek retractors, the occlusal mouth mirrors, that the camera is basically a macro lens that comes with a ring flash. For close-ups, really close-up shots of the teeth, you want to basically at a f/22 setting, and set always to manual. You don't want this to be an automatic, so you got to basically manually focus the lens. Otherwise, if you have it set to auto focus, when you have that mirror in there, you'll get a reflection on there, and it won't be able to really capture that image nicely. A couple of pictures of the intraoral. And if you're needing to take impressions for that, I'm sure you guys have come across already something like Alginol, good Alginol alternative. We use that here in my practice. My staff loves it. No more mixing. And the study models for presentation. Any questions on this area, on this section yet? No?
No, we're good.
Good? All right. Okay.
We can print all that, right? Like you can go into the classroom and print
Absolutely. All this is the classroom. We basically hit the ground running with this, setting this up just a few days ago. We had to work on all this. I didn't get a chance to really do the pre-recording voiceover like we normally do. So that's why I'm going over with you guys. So now with a Changeable Assessment, so you got the kind of like the free gingival margin area, which is the area that isn't attached to the CEJ or the enamel. You got probably about 1 millimeter or so of that, and then you got the attached portion. Here's another illustration of it. And then the attached here. When you're putting in that periprobe, it's going to go in here. You never want to really dig that periprobe too deep, okay? Because otherwise you'll get a false reading on that. And then here you have basically the keratinized tissue, and then below this you have basically the mucosa here, okay, and the vestibule. So you got the mucogingival junction that separates basically the keratinized attached gingiva to the alveolar mucosa. When you see patients with recession here, it's typically going to be like in a canine region, and sometimes the first and second bicuspid area. And really, the causes for that is either it's not just brushing hard anymore. It could be due to abfraction. So basically, they have a malocclusion issue, or they're clenching or grinding hard. That can also lead to gingival recession. So, and for that, you'd want to recommend basically having a graft put in here. And the gingiva obviously will be different colors depending on the ethnicity. You don't want to see something like this. Anything fiery red like that is a sign of either a plaque, tartar, or if they have, sometimes, although rare, if they have crowns and there's metal in the crowns, they can be allergic to it. I recently had a patient here that came to me who basically had PFMs everywhere and had allergic reaction. They were all inflamed and didn't have any deep pockets. The teeth were cleaned. There was no issues like that. So look out for that. Another reason too, sometimes also rare, is if they've had the crowns prepped a little too deep, invading the sulcus area. That can be another constant irritation. Definitely look out for that, and ask your doctor to come in to help diagnose that as well. Some more of that. Same thing as the way before. You want it to be nice and pointed. I'll show you examples here of other ones that are punched out due to gum disease. You want the orange peel look. You don't want anything, you want some texture on there. They call it more like the orange peel kind of look, texturized. Here's an example of a hyperplastic. You got basically overgrowth of gingiva that could be, due to a couple different reasons. Sometimes hormonal. I see it sometimes in pregnant patients or older patients that are on medications that can cause that.
It looks painful.
Yes, this does. Definitely some underlying issue here. This goes beyond anything from oral cavity. Typically autoimmune disease, or there's a couple other rare diseases out there called pemphigus, which basically causes sloughing of the gums, and even affects other parts of the body, their head, their skin, where it just peels off. For treatment for that, you definitely got to refer them to steroid. I mean, normally when you guys see these patients, they've already been diagnosed, they're already on medication. Another form of that pemphigoid. When you see this, definitely refer that to the oral surgeon.
I've seen that before.
You have? Yeah.
Yeah.
It's pretty trippy when you see that. That's yeah. Those I'll refer out. After a while, you don't really want to be a hero anymore. You just want to document, write it down, take the picture, refer it out to the oral surgeon.
So in a situation like that, let's say a hygienist would, because with my experience, you had a patient like that, and the hygienist was able to take it off with the laser. Would you recommend her do that, or just refer out to the OS?
I'm not opposed to removing that with the laser, okay. But I mean, the right thing to do though, what I would do, I would get that biopsy. There's nothing wrong with you guys removing that, or the hygienist removing it, but I would biopsy. I would, like Dr. Nabaria, I would just ask, you'd ask your doctor, maybe even Dr. Germani can help you with that, and have a local oral pathology lab there to send you, and they normally send you basically the tissue fixation canisters with the lab slips, with the prescriptions, and just throw it in there, send it out. It even includes free shipping. Have it send it out, and have them biopsy. They'll send a report. They bill the patient typically too, you know, and that way you feel like you've done the right thing instead of removing something and then it's almost it's a guess. You know, it may have been fine, but what if it wasn't? And it can come back. So that's what I would do. The stages of periodontal disease, you know, gingivitis, like the one we showed you earlier, where the gingival margin is kind of inflamed, typically plaque-induced. What you got to watch out for is once it starts getting to stage 4 of that, that's where now you start seeing bone loss, bad breath, deep pockets, 5-6 millimeters or greater. And here are the classifications of periodontal disease. And sometimes they can be localized. I mean, you could have a patient with, you know, they can have a class 3 in one area, but yet the upper arch is all, you know, a type 1. And I think we're done with that section. Any questions?
No.
Okay. Okay, now we're going to move on to clinical review. And some of this is overlap. I mean, we've covered some of it, so I'll skip over it if we run into it again. So with the medical history, sometimes the older patients are going to need help with completing this. So the front desk would normally help them complete this, but if they come to the back and they mention something that they may have missed up front, make sure you jot it down for them. And any of the medical alerts too, especially some of these other softwares, as you know, you can add a pop-up on their medical alert. For instance, if they're hypersensitive to lidocaine, you want to add that on there. Any prophylactic pre-med that they need for any treatment that's going to cause bleeding, you want to make sure you put that on there. And anything else to help all of you guys keep the patient safe. These are the physical classifications of the ASA. I don't recommend treating anyone beyond ASA class 3. It starts getting really risky. Now you're gambling. So if you have a patient, for instance, comes in, they reported, you know, having had a heart attack. They have several stents in their heart. They get chest pains frequently. You want to make sure you dig deeper. You ask them what tends to trigger it. They get stressed, or they overexert themselves. Make sure if they have their that they have their nitroglycerin, write their handy on them. I would have them take it out, put it on the counter, and have it there. That way, because sometimes even pain can induce this pectoralis angina too, and the tightness of the chest. And the last thing you want to be in a situation is now being with a patient who passes out on you, or now you have to call 911. So you want to make sure you're really prepared and have all that in place. Your oxygen tank, your nitroglycerin. If they have a high blood pressure, you know, make sure you use carbocaine, plain anesthetic, that won't raise your blood pressure. But typically, a lot of patients you're going to see, especially older, they're going to be mostly like class 2. Each one a class 1 and class 2. Yeah, once they start getting to class 3 again, watch out for that. Dr. Germani went over already with you guys with the Extraoral exam, correct?
Yes.
Okay, and she included a video. We did a video too of the Extraoral exam that you guys can check out in the classroom. So I'm going to go ahead and skip this part. And we already went over the intraoral examinations, so we're going to skip this part as well. We'll stop here at the... have you guys seen this before?
No.
Yeah. These are interesting ones too.
Not yet.
These are the more common ones you're going to see, especially the leukoplakia. These can sometimes come off with a gauze. Sometimes it may cause a little bit of bleeding, can be rubbed off, but don't discount this too, because sometimes it could be due to tobacco smoking, and sometimes this can turn into something more serious. But keep a watch on that, and the lichen planus, this one definitely is more serious of the two and can be precancerous sometimes due to tobacco smoking. And there's other ones too that you got to watch out for, but really getting that pocketbook will be very helpful with helping you identify and properly diagnose these.
What's the name of the book that you said?
I have it here. It's let me see if I can pull it up.
Small pocket book of diseases, right?
Yeah, pocketbook
Of
oral diseases.
Okay.
Yep. And it's great. I'm telling you, I love that book.
Thank you.
Doctor, can you scroll back up real quick? I have a question.
Yes.
So that image right there, where is that in the mouth? Is that like on a patient who doesn't have teeth on their gingival tissue, or what is that?
This one here?
Yes.
Well, that one normally due to like basically an infection, like mononucleus, mono.
Okay.
For that.
Is that on the cheek or the tongue? Where is that?
I'm sorry. Roof of the mouth, palate.
Okay.
Yes.
Yeah.
Typically I've seen this more towards the back, closer to the border between the hard and soft palate. Normally, more the heart, but I've seen that too a couple times in the HIV patients too. We went over this already. Go ahead and skip that. And the charting. And we went over malocclusion already. The soap notes. Okay, we are done with that one. On to the medical history. Here they're going to be presenting everything to you guys. Where you guys are right now, is everything being done on paper, or are they doing this online?
Online for me.
Yeah. Good, yeah. These are basic things, of course, to go over. Medical history, always review that. Review that every time they come in, okay? Because especially the older patients, their health, the medications they're on can change even from one appointment to the next. Okay, so make sure always get an update, or have the front desk always request updated medical history, especially you see these patients every 6 months. Things can change. And then when they come in, you want to basically you're doing just a quick scan, quick assessment, how they're walking, their dexterity, things like that. If they're having any speech impediment, anything like that to look out for. Again, updating medical history, a full medical history too, updating every 3 years, and then doing just like a quicker update, smaller, brief update, more frequent. Like in our office, we actually do every time they come in, unless they're coming in within a few weeks, like they're doing treatment, and we don't do the update. We'll still ask them, hey, any changes in your medical health verbally? So you want to get it in paper or online when they come in, if they're coming in every 6 months. For the medications, you know what I recommend too for you guys? As far as a drug reference book, and it's free, there's an online app called Hippocrates. You can download that on your phone. It's great to have. I use it. If you got a patient coming in, they're on multiple medications, you or your doctor planning to prescribe them something different, you want to make sure there's no interaction with that. You basically you enter all the drugs that the patient is on, right? All the medications, and then you enter the one that you guys plan on prescribing them, and make sure there's no interaction.
What is it again?
Hippocrates, EPOCRATES.
EPO.
EPO, sorry.
Yeah, EPOCRATES. And I can always add it in the classroom too.
You say it's an app?
Yeah, it's an app. Common drugs that you'll see. And with the screening, the patients will tell you. They'll more likely tell you than anything else. You know. So and obviously from the medical history, know if there's been any cardiovascular disease, any changes in their heart rhythm, congestive heart failure, things like that. You guys will know that from the medical history. Another important one here that I want to mention is if they're needing an extraction and they happen to be on the type of bone supplement like a biphosphonate, anything like that, like a Boniva, especially one that's injectable. Okay, Prolia, common ones like that. You want to really get a medical clearance on that and make sure that they've been off of that for a while before your doctor goes ahead and does the extraction. Otherwise, you guys or your doctor may run the risk of the patient have osteonecrosis of the jaw, and that's really serious. You don't want that to happen. That's basically an area that just doesn't heal. Again, with the medical alert, you want to have the pop-ups on here. Something new the patient tells you in the chair, you want to add that on here. Here's an example of an actual patient of ours that we added on here. Make sure it's up to date. Getting medical clearance as needed. And informed consent on anything you guys are doing. Okay, we covered already the ASA physical status classification. As I mentioned before, most of your patients are going to be 1 and 2. The 4, I'd be very careful. I wouldn't really treat those. I'd refer them out to get them stable. These are the people that at any time can have the tightness of the chest, gingiva pectoris, and it could go into a crisis. You don't have to worry about these. These you're rarely going to see. Now, as you guys know now, we're living in a COVID-19 world. Just want to talk about that for a minute too. When a patient comes in, you guys have to make sure, obviously, protect yourselves, making sure you have all your PPE, everything you need to have to protect yourselves and each other. One thing we're doing in our office is we assign one person, one of our dental assistants, to do all the temperature checks on everyone, on each other, basically. They even do it on me, all the doctors, on all the staff in the morning, first thing in the morning. Anyone that has anything over 100.4, they really should be sent home and be tested. Okay? That's for the staff. Now for the patients, now we're also doing temperature checks the moment they walk in. We do the questionnaire, the COVID-19 questionnaire, which your front desk should either send them by email or have online, and the patient fill out that pre-screening before they come in, make sure that they don't have COVID-19 or that they've had any of the symptoms or traveled out of the country within last week. And then once they come into the lobby, one of you guys should really do the temperature check on the patient in the lobby before they get taken into the operatory room. That's how we do it in our office. And then have them also use a hand sanitizer, a no-touch hand sanitizer in the waiting room area before they get brought back to the back. Then once they're brought back to the back, always take their blood pressure as well, especially if they're needing any treatment. Anything where they're being getting anesthetized, it's good. Record it on their in their chart notes. So now you're recording their temperature, their blood pressure, and their pulse. It's just a good habit to do, especially now in this new world that we're living. It's a good documentation. You're kind of covering yourself as well. Okay. And now you can get at CBS like the wrist blood pressure cuffs, one that give the pulse rate and the blood pressure at the same time. Most of the patients you're going to see are going to be between normal and hypertensive here, stage 1. Be real careful with the treatment that you provide to anyone who's stage 2 or higher. Okay. If they're a little higher, wait 5 minutes, recheck on a different arm and see where they're at. Sometimes if it's real hot outside, if they just had anything with caffeine, like coffee, that could also raise their blood pressure. So when you see that, don't discount and think automatically it's hypertensive. I'd wait 5 minutes, recheck again. Now, if it's anything really over 180, I would not do anything that's invasive. And then strongly recommend that you see their primary doctor to get that blood pressure under control. Talked a little about here about the pulse. You want to see between 60 to 100. Different pulse points. And the respiration rate. Now, for all this, really, the only way to really check this is with pulse oximeter down here, which if your doctor has that or offers conscious sedation, then that's another way you guys can record that. Okay. Mortality. When you see these patients, they're typically going to have a stent or more. Check and see when was that stent put. If there was anything within 6 months, you want to make sure that they had a pre-med prophylactic antibiotic. You see any of these patients too, just be careful with them. Treat them slow. Have a clearance with from their primary doctor. Sometimes you'll see swollen ankles, swollen feet with this group. Even if they don't have congestive heart failure, watch out for the syncope, especially the older patients. You raise them a little too quick, as I'm sure maybe some of you guys have seen. They get lightheaded. You don't want them to pass out, so raise them up very slow. Give them a few minutes to get themselves together before they stand. Otherwise, they could fall. We already went over the angina pectoris, the tightness of the chest. Make sure they always bring their nitroglycerin for any treatment, because at any time that can trigger it. The stroke, with this one, again, you have to be careful with these risk factors. The blood pressure, if the blood pressure is too high, do not treat them, refer them out. You don't want them to be at risk of getting stroke, especially in your chair. Talking a little more about the strokes. This one's a little bit more of a transient. It's something that they could get that lasts for maybe a few minutes and goes away. But you also got to be careful with this one, the TIA. Another thing that can cause this too sometimes is actually women on birth control pills. They can get sort of like a very transient stroke, and COPD. So I'm sure you guys have seen. They normally come in with their oxygen tanks. When you're treating these patients, they may come in with their caregiver or their spouse, and they're getting treatment. Make sure that they have an extra tank in the trunk of their car, or bring an extra one, especially the treatment's going to go for a little while, for more than an hour, between waiting to see the doctor for an exam, for getting a cleaning, or if you guys are doing any treatment on them, you want to make sure you're covered, okay? Because sometimes with these patients with COPD, they require a lot of oxygen, a lot of 100% airflow coming into them. I had one recently where they needed to have that cranked up real high at level 8, and we're going through that oxygen fast. So make sure that you have a spare or two that they bring, that they come prepared for that appointment, so that way you don't have to reschedule them halfway through the appointment. With your diabetics, you typically want to see them in the morning if all possible. Make sure they've taken their insulin. You don't want to see a type 2 in an afternoon, or if their appointment's going to be really long, because they do need to eat. Make sure of that. When you guys are back at the office too, just go through your emergency kit, make sure all this is updated, and you have those blood sugar tablets in there. I mean, you can even use like cake frosting, or a little bit of juice too, anything like that, to help them if their blood sugar level drops and they're getting lightheaded. They're reporting lightheadedness or wanting to pass out. Okay. Alzheimer's. They'll normally come in with a caregiver. This one we don't see too often. More pneumonia. If they have pneumonia, they typically are going to be coming into the office. Common medical conditions. The difference between the acute and chronic. You want to make sure for your asthmatic patients too, with your emergency kit, that you have an albuterol ready to go should they need it, if they're reporting trouble breathing. This, they can be treated by their primary doctor. We don't really see patients with bronchitis much, but the asthmatics, we do. Same thing with this, normally with the heart disease. We don't see this too often. We've seen very few from older patients who've had this. Peripheral disease, kind of an overview on that one. The heart murmur, nowadays you don't need a prophylactic antibiotic for mitral valve prolapse. Make sure you also look at the American Heart Association guideline for an update on that. Every few years they keep updating it, and it's less conditions that you need to basically be prescribing the prophylactic antibiotic. But years ago you needed to prescribe it for this. Arrhythmia, basically an irregular heartbeat. Normally they're on a medication to control that. Dilantin is a common one. The stents and the hepatitis. Now they're coming out. I think they already came out with one for the hepatitis C, so that's one we're going to be seeing less and less of in the future. And on tuberculosis too, this is a rare one too. You're going to not really see too often. You got a patient coughing too much, make sure refer them out. Especially now, hard to know whether it's this TB, is this COVID. I would refer them out. Immune disorders, they tend to be more on steroids to help control their autoimmune issue. Nowadays with HIV and AIDS, this is kind of really not much of an issue at all anymore. In my practice, we see a lot of HIV patients. They take their medications. They're fine. You can do extracts with no problems. You can place implants. You can pretty much do anything you would on a healthy individual as long as their CD4 count is normal.
How would you check the CD4 count?
You know what? These patients, a lot of them actually know their numbers.
Okay. Yeah, I've never even heard that, so I don't even know what that means.
Yeah. A lot of them know their numbers. I just ask them, have you gotten your CD4 count lately? And they'll tell you. They'll let you know. When I first got out 15 years ago, I mean, it was a different world than it is now. I mean, it was still. It was harder, you know. You even had, even going back further than that, you had some doctors that were really uncomfortable treating this population. Nowadays, not an issue. They're just almost as healthy as someone else, and they can live a long life. But it's still a good idea, especially when you're first meeting them, making sure their CD4 count is fine. If they're not sure, then request one from their doctor just to have that updated in a chart. I think it's a good idea because. If they are immunocompromised, or CD4 count or their white blood count is real low, I mean, that can affect the healing too, especially if they're needing treatment. They're needing even deep cleaning, right? Scaling root planing. They're needing more invasive treatment. It's just good to make sure that they're covered. At least in my experience, from what I've been seeing with our patient base, they're that one group. They're really on top of it. The medications are a little better now that they're taking, and I'm not seeing that issue much. The autoimmune disease. There's another one here. There's a common one here too that is missing out here, but I wanted to mention that you're going to probably encounter, called Sjogren's syndrome. That one's more. It attacks the tear ducts. They have the dryness of the mouth too, the salivary glands. That's a one I see more frequent with older people. Another autoimmune, and for that one, what you can do, recommend that they're constantly staying hydrated, drinking plenty of water. You can also prescribe or have your doctor prescribe pilocarpine. It's good. It actually helps stimulate their saliva, keep them hydrated, and also to help prevent cavities with that one. And we have gout too, kind of more attacking the joints. The Parkinson's, more of the tremors. Multiple sclerosis. This is one that you may encounter too. I typically see this in women, where that it affects. It's a degenerative central nervous system disease. It can affect their balance. It can even affect their eyesight, and it's sad when I know some people have been diagnosed with this one, and it's sad. It's really hard to treat. Post-traumatic stress disorder. This obviously it's going to be really hard for you to know unless they mention something about it. Here we got the spinal curvature. You normally find this on older Caucasian ladies too. Some other fancy words here for you guys to know. These are helpful knowing these prefixes and suffixes, especially if you guys are getting, you get the medical clearance forms from the doctors, or even past medical records from patients. Some patients will come in with a stack full of their medical chart, and this will help you too with understanding what's going on. Some more fun words for you guys to practice on your spare time. Any questions so far on this?
No.
Okay. Oh, INR. This one, if you have a patient who's on reports being on Coumadin or warfarin, in Canada they call it one way, here we call it another, but warfarin or Coumadin, you want to make sure that you get a most current INR reading from their doctor or from their lab. Normally, sometimes they get it at a lab center. You want to get those readings. You want to make sure those readings are as close to the time of when they're getting the surgery, okay? You want it to be somewhere between 1.5 to 2.5, the INR reading. What happens if it's outside of that? You might have a little bit of problem in controlling the bleeding. Okay, so make sure that one's an important one. So I'd normally, if I'm going to schedule a surgery on Thursday, I tell them, hey, try to go on the Wednesday before, get that INR reading for me. And that way we make sure that we keep you as safe as possible, able to control it. Not too much of an issue for even one tooth extraction. You can still control it using local measures. But when you're talking about 3, 4, 5 teeth that you're extracting, you want to make sure that that INR reading is within that day or the day before, not more than like even 2 days out, because then the reading isn't going to be as accurate and it's not going to help your doctor.
Is that also for cleaning?
For cleaning, no, cleaning not so much.
Okay.
It's just going to be a little bit of a blood bath for your hygienist, but I mean, it might be a little overkill getting medical clearances for things like that for the cleaning. What I normally recommend for the hygienist is just to kind of administer a little bit of lidocaine in there that has the epi to control the bleeding,
Okay.
or they can have some kind of like an astringent epinephrine liquid in there that they can just with a cotton ball just kind of rub back and forth around the gum to control the bleeding a little bit. Some more chart abbreviations. Any other questions about this? Nope. Okay. Moving on to the last part. Patient chart, and we covered some of this already. Some of this pertains more for your doc, but when you guys are writing your notes, obviously the soap we went over already, examples of it. I doubt any of you guys are going to be writing anything, so you don't have to worry about putting a line through it. Just make sure you keep that updated in their chart. Just delete it and write it. And with the charting, make sure all that's updated. Anything that's damaged, anything that, any restorative treatment that they've had elsewhere, documenting all that, okay? Here are the common ones: abrasion, attrition, caries, restorative work that they have, more restorative work. We went over all this already, so I'm just going to skip it. Make sure you get consents. You got to get consents for everything. Exams, radiographs. Even if they decline the radiograph, I'd still recommend that they assign one that they're refusing to have radiograph taken. This is what they'd be doing online or coming and filling out at the front desk, right? Their dental chart, dental history, which you will be reviewing once they come to the back and see you. Their chief complaints, issues that they've had in the past, their medical history. This part's all important. Allergies that they have, medications that they're on, and the list of medications. The medical alert that I mentioned earlier, anything on there, put it in your pop-up. As well as uploading anything, previous dental records that they have, lab prescriptions, insurance info. You guys know this already. So we kind of went through everything. Do you guys have any other questions? Anything you guys want to cover? Anything I've missed?
Nope.
Anything with the COVID-19? Anything outside of dentistry with a practice? Anything at all? Okay. All right. Well, okay, we're done.
Thank you.
You're
Thank you
welcome.
so much for all the
Thank
information.
you.
We appreciate it.
I hope you guys found it helpful. Yes. I'll see you guys next time, okay?
Well,
Enjoy
thank
your
you, Dr. Cross. Give Dr. Cross a big hand.
Yeah.
Yay!
Hey, well, it doesn't mean you may not
Fantastic.
get one.
So I have recorded Dr. Cross talking. Since you guys want to review it later, this is going to be on your Google Classroom. So if you want to study his material that he taught, you have the PDFs available. You also have a video from him where he's showing an intraoral and an extraoral exam that he recorded specially for you guys, the way he does it in his practice. And this entire presentation, I recorded it using a screen recorder for the first time. So I hope it came out as a good recording. If not, then I'll have to improve my technique for next time. I'm going to post this on the Google Classroom. And that way you guys will have access to this as well.
Okay.
All right.
Okay.
So I'm going to resend the schedule, and I'm also going to send you guys a survey. We'd like your feedback about this a Google/Zoom style teaching, and if you guys would like more of it, because I know you guys mentioned that you have to work on some Saturdays. But if you found this useful and you're enjoying it, maybe we can continue it. But I'm going to go with your feedback because we're doing this for you. And we're doing this to support you and best create a classroom-like environment during this COVID time. So, so expect an email from me along with a Google feedback link that I'd like to receive from you. Also, please email me which lab group you guys would like to be in, because I'd like to lock that down by this weekend.
If we already sent it, we don't have to send it again, right?
Correct. And hopefully that lab group is still available. Right. If that lab group is still available, then that'll be assigned to you. If it's already filled up, then I'm just going to put you in the next one. If you have a preference and say, hey, I'm coming from Tracy, please give me afternoon lab, then I'll give you afternoon lab. All right. Well, thank you, Dr. Cross. This was fantastic. I learned a lot. I've been writing notes about the Invisalign app and about the pocketbook, and I learned a lot of new things from you.
It's great. I even recorded a video using the Velscope, which I'll add that to the classroom also. I have that already recorded. I didn't have time to add it beforehand, but I have that. I can add that later today, or I can send it to you, Dr. Giovanni, if you can help me load it to the classroom.
Absolutely. This was really enjoyable. My first dental class on Google Meet. And I actually got a chance to dress up today. You know, I felt like I'm going out, so it feels really good.
Oh, wow. I wanted to dress up a little more, but it was a Saturday. I didn't want to overdo it.
Anyways, well, thank you all. It's 11:49. I know you guys have things planned for Father's Day tomorrow, and it's a beautiful sunny day, so we're not going to keep you. If you have any questions for Dr. Cross, or if you have questions about what I taught, you know how to send us an email. The best way to communicate is through the Google Classroom, because Dr. Cross is very responsive and so am I. So we're going to move all our communication there because all the students can see the question and answers together.
Okay.
Especially the people who missed out on this. All right?
Okay. Bye, doctor.
Okay. All right. Bye-bye.
See you next time.
Okay.
Doctor,
Bye.
Okay. Bye. Bye.
Bye-bye.
Happy Father's Day, everybody. Bye.
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 Bye.